Hello and welcome. While we wait for more people to enter this expo session, I would like to remind everyone that November is Epilepsy Awareness Month. This year, our campaign is focused on encouraging people impacted by epilepsy to speak about their experiences through the Silence the Stigma campaign. If you haven't already, visit efmn.org to find more information. I would also like to remind everyone that we have open exhibitor meetings tomorrow starting at 1 p.m. If you are interested in speaking one-on-one with organizations and companies that specialize in epilepsy care, treatment, and devices, please schedule an appointment at efmn.org or email admin@efmn.org for assistance. Thank you for joining us for the Innovations in Epilepsy and Wellness Expo. I am Heather Bessanen, Associate Executive Director of Mission and Strategy at the Epilepsy Foundation of Minnesota. Today, we welcome Mahado Ali to discuss health equity and chronic health conditions. Before we start our session, I would like to go over some housekeeping information. For this webinar, your cameras and microphones are hidden as the focus will be on the speakers and presentations. Following Mahado's presentation, we will have a panel discussion with Mahado, Tammy Sinkfield, Dr. Rupert Excande, and Tameta Kozart to talk more about today's topic. We will close with a Q&A session where you are able to ask questions to our experts. You will see the Q&A icon on your Zoom toolbar, and you can ask your questions there. I have the special honor of introducing today's moderator, Tammy Sinkfield. Tammy has proudly worked at Gillette Children's Specialty Healthcare for 24 years and was the first African-American nurse hired. In her current roles as nursing supervisor, as a founding and continued member of the Diversity, Inclusion, and Equity Committee, and especially as a premier anti-racism advocate for organizational change, Tammy remains steadfastly committed to transforming the healthcare quality and experiences for patients and their families. And she is a fierce champion in the elimination of barriers that prohibit an inclusive and equitable environment for all the staff. Tammy received her master's degree in transcultural nursing practice and her doctorate degree in transcultural nursing leadership, both from Augsburg College. Tammy is the 2018 March of Dimes Distinguished Nurse of the Year and the 2019 Minnesota Hospitals Association Caregiver of the Year Award winner. She is a single parent of two wonderful young men, twins. She is an author, a beloved daughter, and an advocate for social justice, working tirelessly in her time off to lift consciousness and raise awareness on issues of inequities, institutional racism, discriminatory practices, and inclusion. It is my privilege to welcome Tammy to today's session.
Good morning, everybody. I am so excited to be a member of the Epilepsy Foundation of Minnesota Professional Advisory Board, and especially to be here with all of you this morning as moderator for this session of health equity and chronic health conditions. The Innovations in Epilepsy and Wellness Expo is designed to meet the needs of those impacted by epilepsy. Having the expo via this online format spanning over 2 weeks will provide information and education through speakers, presentations, and exhibitors. The change from being in person to online means EFMN can feature more epilepsy experts like those we'll hear from today than ever before on a range of relevant topics, providing something for everyone based on the relationship to epilepsy and the type of epilepsy. I love the tagline from EFMN this year's Epilepsy November Awareness Month: Save a life, silence the stigma. This year, more than ever, I've known stigma, shame, and doubt are most apparent. The three practitioners that you'll spend the next hour and a half with are three of the many local champions who are diligently working on behalf of the more than 60,000 people living with epilepsy in Minnesota and northeastern North Dakota who feel some of that stigma. Our lives this year have been impacted by so much: economics, concerns for the future of medical coverage, classism, racial injustices made evident by George Floyd's death, elections, and a most catastrophic stressor for all of us has been COVID-19 and the health inequities it has revealed among people who are poor, marginalized, diverse, and those affected by chronic health conditions which compromise them and their comorbidities. I appreciate this year especially that EFMN is bringing awareness to the individuals impacted by epilepsy through sharing their stories. Having these stories acknowledges the need to understand a patient's life experiences, to deliver effective care, and has the potential to improve patient engagement, treatment adherence, health outcomes, and provider and staff wellness. This is one of the first steps for understanding health inequities and in approaches for trauma-informed care. Without further ado, it is my honor to introduce our lead presenter, Mahado Ali. Mahado Ali is a trauma-informed care project specialist at Center Care and a consultant for minority businesses. Mahado is also an adverse childhood experience trainer and bounce back trainer. Prior to her current role, Mahado held various positions such as community health worker, working with different minority groups and bridging the healthcare gap. Mahado holds a BA in political science and community health. She is currently pursuing her PhD in business management with a focus on leadership. For over a decade, Mahado has extensively fought for closing the health equity and social determinants of health gaps, and has actively engaged in bringing attention to these issues. Her work focuses on socioeconomic and racial ethnic disparities in health. Let us all welcome Mahado Ali.
Thank you, Tammy. Thank you for having me here today and being a part of this conversation on health disparities and with the Epilepsy Foundation. Again, my name is Mahado Ali, and I'm grateful to be here. Like so many people across the world, I too have experienced racial disparities, and my family have. I would first like to start out by saying that I feel deeply outraged by the brutal and senseless killing of Breonna Taylor, Ahmaud Arbery, and George Floyd. We stand in solidarity with the millions of people lifting their voices in protest and join the countless more in reflecting on what we can do to make this a turning point for racial inequality. Inequality comes in many forms for people of color, both here and abroad, but race-related health disparities are amongst the harshest and most resistant to progress. Over the last few months, COVID-19 pandemic has brought this unfortunate reality into even more clear focus. Being a Black female further amplifies these inequalities because I almost became another statistic who died from pregnancy-related complications because my provider's office would not schedule an appointment for me, even though I complained about pain and leaking at 22 weeks of pregnancy. And when I went to the hospital at the ER after few weeks of waiting and I went there with pain, I immediately had a C-section, and the providers assumed that I did not speak English and did not bother to explain that to me at all. So I went into C-section surgery by myself, screaming, kicking, and ended up with a trauma from that itself. I dealt with anxiety and panic attacks for a really long time, and being a refugee person and coming here at the age of 13, I've also dealt with my own adverse childhood experiences, which added on to my challenges and journey with the healthcare disparities in the US. Also having a premature kid at 25 weeks who was fighting for his life and have dealt with a lot of health complications and at the beginning stage with some even seizures. I wholeheartedly am pleased to be here today and to present on this topic. Next slide, please. When it comes to health disparities, it's been said of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Dr. Martin Luther King has said that, and he's been fighting injustices and inequalities for a long time before he was taken away from us. He did not die for us, he was taken away from us. Next slide, please. Before we dive deep into the presentation, let's quickly review some of the healthcare definitions. So a health means the state of complete physical, mental, and social well-being. Healthcare is the prevention, treatment, and management of illness and the preservation of mental and physical well-being. It is a service offered by medical and allied health professionals. When it comes to healthcare disparities, World Health Organization identified this as differences in health disparities, differences in health outcomes that are closely linked with social, economic, environmental disadvantages, and are often driven by the social conditions which individuals live, learn, work, and play. Health disparities refers to differences in outcomes or disease burden between disparate groups. Lack of health equity is what causes these differences. A healthcare disparity typically refers to differences between the groups in health insurance coverage, access to use, and the use of care and quality of care. Some populations experience more social determinants of health than others, which result into health disparities and health equity injustices. Next slide, please. When we look at the determinants of health, we must ask ourselves two questions. What makes some people healthy and others unhealthy? How can we create a society in which everyone has a chance to live a long and healthy life? So some of the determinants of health fall under several broad factors and categories. It falls under the behavior, physical environment, social, biology, or individual and genetics, as well as policy making. Next slide, please. The social determinants of health probably have more of an impact than any biology or genetics as it relates to race and ethnicity and outcomes when it comes to chronic diseases. It is the interrelations among these factors that determine individual and population health. Because of this, interventions that target multiple determinants of health are most likely to be effective. Determinants of health reach beyond these boundaries of traditional healthcare and public health sectors. Sectors such as we can see on here on this chart, these sectors include education, housing, transportation, agriculture, and environment that can be important when it comes to improving population health. Next slide, please. This is a study done by the University of Washington by Chris Murray. He basically cut America into certain segments looking at real life expectancy and longevity. This study showed inner city urban Blacks have shorter life expectancy of 10 years or more in comparison to other races in America. The research revealed that a difference of 32 years between the longest living and the shortest living groups in the US. The observed disparities in life expectancy cannot be explained by race, income, or basic healthcare access and utilizations alone. We need to look more into these social determinants of health. And I would highly encourage for everyone to look further into this study. Next slide, please. What is the impact of epilepsy? We must ask ourselves. Approximately 50 million people worldwide have epilepsy, making it one of the most common neurological diseases globally. Nearly 80% of people with epilepsy live in low-income and middle-income countries, and they do not get treatment that they need. In some regions in Africa, this can be as high as 85%. Those with epilepsy have 3 to 6 times greater risk of dying prematurely. And immigrant children with epilepsy oftentimes don't receive the care that they need and often are isolated from normal interactions, as oftentimes, especially in Africa, seizures or epilepsies are seen as demonic behaviors. So the stigma that follows with that of having an epilepsy, there was a recent study that was done, a survey that showed amongst hundreds of Spanish-speaking adults in the US, we found out that 8% believe epilepsies are sins which causes seizure, and 10% agree that exorcism is a viable remedy. Disparities in treatment for this patient population may be explained by cultural understanding of the disease, further highlighting that education may be a more heavily weighted factor in treatment of choice. Next slide, please. Here is another study that was done on disparities in epilepsy. This study specifically focused on Hispanic patients and African American patients, but has also touched base on non-speaking patients, non-English speaking patients as well. The studies reveal that African Americans, Hispanics, and non-speaking English patients underwent surgical treatment for epilepsy at rates significantly lower than white patients. Access to specialists is also a major issue when it comes to equal treatment. So when we look at this chart in the blue area where it says access, we struggle with the same amount of issues, whether you're Hispanic, Somali, or African American. But so the other areas might be a little more larger for certain groups than others. For example, when it comes to communication barriers, language incompatibility between patient and physician can lead to patients experiencing difficulties in communicating in English when sick, compared to English-speaking US-born patients with epilepsy. So working as a community health worker, I've seen patients who had misdiagnosed treatments or did not get the medications that they needed to be treated for the chronic disease that they were dealing with. So communication is a huge barrier if there are no interpreters or translations available for patients. Also, education is another portion where both communities struggle with. And as a minority as a whole, we generally struggle with the education portion, especially people that are dealing with epilepsy, because people with epilepsy have lower education and health statuses compared to healthy adults. They are also less likely to complete secondary or post-secondary education compared to the general population. African patients had greater mistrust for medication compared to white patients, despite having similar education levels. This disparity in attitude towards medication might be related to knowledge about epilepsy. So although education is an issue in both parties, and that language and other barriers that affect in the Hispanic community, however, it's the same thing for the African American community as well. Patients of varying races and ethnicities may cope with diseases differently and seek treatment options dependent on their beliefs. So that goes into the factor of the religion as well. And then when we go down here and look at the trust between patient and physician, there's a mistrust between the patients and physicians because of the long history of medicine trial in America, in the African American community, as well as the racial inequalities that exist, which makes it difficult for patients to trust their white providers. One study indicates that African American patients had significantly more seizures and scored higher on the general beliefs about medicine questionnaire, indicating a higher mistrust for the medication. If there is a mistrust, there is a huge issue there. And then we come down to the support and physician biases. So when it comes to the support, this category encompasses of income, family support, employment, and physician bias, as each of these factors can have an effect on healthcare. Having epilepsy is associated with lower incomes, higher unemployment, and lower educational attainment. So socioeconomic status is also associated with poor medication compliance, which could discourage patient population from getting epilepsy surgery, or becoming a candidate for that. So people with epilepsy living in poverty experience higher psychological distress and a lower self-perceived health compared to other groups. And then when it comes to the physician biases, there's a growing evidence about the physician biases and health disparities. Data reveals that African American patients were rated as less intelligent, less educated, and less compliant with medication and recommendations compared to white patients. I have seen that at firsthand working with providers and nurses on some of these comments that I've heard in regards to the Hispanic patients, the Somali patients, our other immigrant patients, as well as the African American patients. And the biases starts at way before the patient enters through our door, so that we need to view our physician biases as well. And then next slide, please. And so when we have patients that are struggling with all of this, it creates an economic burden for the United States and for our organizations. Between 2003 and 2006, we spent $1.24 trillion in combined cost of health inequities and premature death. We could do so much more with that money by bridging the gaps and creating programs to help these families and people that are struggling, instead of spending on the inequalities and premature death after the fact. Socioeconomic health inequalities imposes a direct economic burden of at least $6.2 billion annually, or over 14% of total expenditure on acute care patient hospitalization, prescription medication, and physician consultant. Next slide, please. So some of the sources of disparities in care are at a patient level, and at a patient level, sometimes it could be patient preferences. So patients might prefer a minority provider because they have more trust in minority providers than non-minority providers, or having other people to help, but looking at it at a patient level is critical. Also, there is disparities in the healthcare system levels as a whole, because there's a lack of interpretation and translation, as well as everything else that follows into the structural racism. And then there's the provider level, which is the bias, clinical uncertainty, and that is another source of disparities in care for people of minorities. Next slide, please. So when we want to measure healthcare disparities, here's the things that we need to look into consideration and things that we need to look at. So prevention quality, some of the indicators, the ambulatory care, the sensitive conditions. Also, we need to look at the vital statistics. So our organization, what we do is we divide by race and look at where the numbers are at. For example, for colon cancer, the numbers for the asthma in African American children, or we look at the place of birth and then the death and everything that comes along. Also look at the access of healthcare. So is there health insurance available? Do they have insurance? Also look at the geographical areas. It's important to look into the demographics. The socioeconomics, like I said, plays a huge role into a lot of the patients and minorities that we work with. And then clinical indicators, such as depression, anxiety, migraine, heart disease, peptic ulcers, and arthritis are certain diseases that follow with the epilepsy. Next slide, please. According to the Institute of Medicine, minorities are significantly less likely than the rest of the population to have health insurance. Lack of health insurance negatively affects the quality of healthcare received by minority populations. Next slide, please. And here's a quick fact that I found it helpful. So Blacks are 2 to 3 times more likely than whites and Hispanics to be hospitalized for potential preventable conditions. Black men and women are more likely to die from heart diseases in comparison to other racial ethnics. Minority women have lower rates of breast cancer than compared to white women, but were more likely to die from the disease. And life expectancy, there's a huge gap between life expectancy of Black men and white women, which is 10 years, and that's a problem. Next slide, please. Another statistics that I found is 1/3 of our population are minorities. 50% of the people 50 million people are uninsured. 50% are minorities, which is 25 million people. 56 million people experience rates of preventable hospitalization. 2 times that are non-Hispanic whites. 19 million patients are served by the HRSA. 63% of that are minorities. 92% have income below the deferral poverty line. Next slide, please. Some of those influencing factors in health statuses are race, ethnicity, religion, socioeconomic status, gender, age, mental health, disability, sexual orientation or gender identity, geographic location. So to bridge this gap, next slide, please. So to bridge these gaps, we need to look in disparities in health and human services in infrastructure and workforce. So when we look at the population, the Hispanic population in the US, we have 16%, but less than 6% of the Hispanic population are physicians. Also, we have 24% of the US population are African Americans, but 6% of those are physicians. 24 million adults in the US are limited in English proficiency. So when people are limited in English proficiency, we as organizations and healthcare organizations need to bridge that gap and address the elephants in the room. So as an organization, the one that I work for in CentraCare, we created a programs in the diversity and inclusion programs that provide scholarships and also help with other areas in bridging the educational gap for our employees and people from the community to attend school. We also have bilingual community health workers and community health specialists that consist of RNs and Somali psychotherapists, Hispanic psychotherapists, and myself, in bridging those gaps on a community level. We've also created a community clinic for the Hispanic community to provide services to undocumented patients so that they can receive care and close that gap a little bit. Another organization that I think is doing a wonderful job is the National Health Services Corp, which invests in healthcare workers by placing health professions in health professional shortage areas. And in return, they have 7,000 national health clinicians who go to those areas. In return, what they do is they provide loan repayment or scholarships. So 33% of those clinicians are minorities, 50% of them are in community health centers. Next slide, please. I also did a little bit of research and looked into other organizations that have successful nodes, and I found that CDC Racial and Ethnic Approaches to Community Health, the program called REACH, to be an extremely great program in bridging the gap and health disparities. What they do is they provide and help seek better health. They change local healthcare practices. They implement evidence-based public health programs. also, they, as an organization, we follow their model by supporting recipient partners with that will establish community-based programs and culturally tailored intervention to address preventable risk behaviors. Another program that I really like is the Communities Putting Prevention to Work, which provides nationwide support for organizations that build community-based policy, provide nutrition and physical activity, as well as tobacco control. And I think that this project addresses disparities in chronic diseases among racial and ethnic subpopulations, socioeconomic groups, and geographic settings. Next slide, please. Race in medical care. We can always touch base on race in medical care, but there has been a history when it comes to race in medical care. And we all know that minorities receive fewer procedure and poor quality medical care than whites. Why? It has a lot to do with structural things, mechanisms. So institutional discrimination, socioeconomic status, segregation, internalized racism, and the inability to communicate with patients who are different from providers. Those are the reasons. Next slide, please. So we think of poverty just in the health field, but it's more into that. I look at it as more of the iceberg. What you see what you see on the top, and you don't see anything that's at the bottom or under the water. So when we look at Minnesota, and I did a little bit of research, poverty is related to health. People living in poverty have a greater risk for things like asthma attacks and hospitalization. Although Minnesota has a lower proportions of people living in poverty than the US average, it affects 1 in 10 Minnesotans and 1 in 9 children in Minnesota. That is a problem, especially with the children and families who are struggling with epilepsy and other health chronic conditions. Next slide, please. Racial and ethnic disparities in poverty. This is a chart that is in the most recent 5 years that Minnesota has done a research. And this chart indicates that just under 1 in 3 people that identify as American Indian or Alaskan Native, which is 29%, or Black or African Americans, which is 28%, are in poverty, which is significantly higher than poverty among the other race or ethnic groups. Next slide, please. Recently, I've been working on projects that help bridge the gap, especially in education. So in the area that we live in, we have a lot of refugees, especially Somali and as well as African Americans and Hispanics. And one of the things that we see is a huge educational gap, because moving into distant learning, most of these families, let alone speaking English, are not able to navigate the system, and they're not able to help their children with assignments or help them out with anything. So yesterday, I received a call from a mother who said that her daughter's missing 40 assignments. Her 8th grade daughter is missing 40 assignments, but she's a single parent of 5. She has to go to work every single day. The kids are at distant learning. She thinks her daughter is doing her homework and assignments and turning in. But the mother found out that she's not doing any of that because she received a letter from the school with a court date for her daughter missing all those assignments. So being a refugee, an immigrant, and also going through what has been happening in this political climate, on top of that, we have to add on to the disparities in the education. And this poor parent had to deal with the anxiety and stress of knowing that she has to go to court on top of everything that she's dealing with, and she does not know what the outcome is and does not speak English and has never been to court and does not know how to navigate that. So the relationship between education and health is never a simple one, because this specific parent is diabetic and has high blood pressure, which became an issue because of the stress level that she was experiencing during this COVID-19, and ended up in the ER multiple times herself. Next slide, please. So when I said that there's a relationship between education and health, it's never a simple one. I feel like this specific chart kind of explained, or diagram that I would call it. I looked at 3 sections, which is number one, education, which education can create opportunities for better health. We all know that. So the benefits of health, of education is income resources, which is a better jobs, which is a higher earnings, resources for good health. Resources for good health means that families with the higher incomes can more easily purchase the healthy foods, have time to exercise regularly, and pay for health services and transportation. Also, there's another component to that is the social and psychological benefits that reduce. So having a job and education, it reduces stress level, the social and psychological skills that creates a social network, health behaviors, knowledge and skills. Also, it's important to have healthier neighborhoods, which means having a safe neighborhoods. The second part of that is the poor health that affects education. So the reverse casualty, that's what we call it. So the relationship between education and health is never a simple one. We all agree. Poor health not only results from a lower educational attainment, it also can cause educational setbacks and interfere with schools. So, for example, children with epilepsy, asthma, and other chronic illnesses may experience recurrent absences and difficulty concentrating in class. Disabilities can also affect school performances due to difficulties with vision, hearing, attention, behavior, absences, or cognitive skills. And the third one is the conditions throughout the life course, beginning in early childhood that affecting both health and education. As a trauma-informed care, I specialize in adverse childhood experiences. So what happens to a person from age 0 to 18 and how that affects their life in the future. A third way that education can be linked to health is by exposure to conditions. So basically being in early childhood, which can affect both education and health throughout life, conditions at home, socioeconomic, and other contextual factors can also create stress, cause illnesses, and deprive individuals and families of resources for success in school, the workplace, and healthy living. Some of the parents that we work with, as this non-English speaking patients that we work with, have issues with the education system when it comes to their children, especially children who are struggling with epilepsy, since parents are not able to advocate for themselves or advocate for their child. So they're always looking for someone else to help bridge this gap. And schools don't have enough bilingual staff to help bridge this gap, let alone the healthcare system that we're dealing with. Next slide, please. So what could we do? There's a social policy in place. Social policies make decisions about jobs, economy, education, and reforms. It is an important driver of educational outcomes and can affect all of the factors described in this brief. So, for example, underperforming schools and discrimination affect not only educational outcomes, but also economic success, the social environment, personal behaviors, and access to quality healthcare. So when I go to board meetings and committee meetings, I always advocate for the educational gap to be reduced and to provide services to families that have unique challenges. If we don't speak up for the people that are not at the table, there's nobody else that will speak up for them. So it's important for us to focus on the social policies that affect the education system itself. But in addition, individuals with low educational attainment and fewer resources are more vulnerable to social policy decisions that affect access to healthcare, eligibility for aid, and support services. A lot of people are not aware of how policies have a bigger impact on communities that we're serving rather than the work that we're just trying to do right now. Next slide, please. So areas we need to consider in healthcare disparities in the healthcare are workforce care, population, and data collection and research. I cannot stress enough that there is not enough work that needs to be done in those areas and how to bridge those gaps. Next slide, please. What can we do? And some of the recommendations that I have. So my recommendation is to allocate funds that look into structural racism, because things like this create disparities and a gap for communities that are in need, whether it's poor white folks, poor Black folks, poor Hispanic folks. Poverty impacts all of us at the end of the day. So my recommendations is provide further research that address health disparities in epilepsy, especially in the areas of communication, provider biases, education, access to certain care and treatment. Also, improve clinical outcomes. How can we do that? How can we reduce burden of chronic diseases? How can we improve sustainability of the healthcare system? How can we inform, engage individuals and families, because those are more important than managing the chronic disease. By engaging them and educating them and teaching them, you are creating a pathway for better health. So also provide support. Oftentimes, a lot of the families that we work with lack support. They don't have families, friends, or just a systematical support. So it's important that we look at them as, hey, how can we help you beyond these doors that you're coming in for this appointment? What could we do further to help your life better so that you can come to this appointment in a healthier mindset, and that the information we're giving you, you're processing it and you're understanding it better. And that's where the education comes. Also, we need to provide a coping skills. A lot of the families, especially immigrant and refugee families, when it comes to mental health and epilepsy and chronic diseases, they feel like they're outcasted, and the stigma that follows that. So it's important to provide coping skills and self-management tools, even for the ones that are supporting those with epilepsy and other health issues. Also provide community programs and resources. I barely see Somali people with epilepsy or kids with epilepsy being engaged into other activities. So it's important that we be more mindful and we take the extra step to include others. We often talk about diversity and inclusion. We always got the diversity part, but we don't have the inclusion part down. So it's important that we fight against those and that we come together to advocate for those that cannot advocate for themselves. Next slide, please. What can you do? So here's what you can do to help. People living with epilepsy still need your help, and it's important that you take action. Make sure that you advocate and write to your key politicians, you write to organizations and initiatives that help minorities with epilepsies and in other areas too. So if you have a client that has epilepsy, you're also uh, you also need to look into the family too. What are their needs? If they're having issues with housing, they're worried about where they will get their next meal, or if they're worried about how to pay for the electricity, or they're worried about getting a diaper, they will not do what you want them to do. So it's important that we advocate for housing policies, that we advocate for foods, we advocate for everything. So health disparities is not just about the health, but it's all about the social determinants of health is what impacts at the end of the day, the overall health of our people. Make sure that you work with Department of Education and Health and Long-Term Care and our community partners to ensure that students and individuals with epilepsy are safe while at school and can be a part of the education success stories, and also challenge them as much as that you can. Also, let's create a better world for people who are different from us, because at the end of the day, when we cut, we all bleed the same and we're no different. So it takes a village to raise a child, and a lot of people are missing out on that village. So let's come together and let's fight these inequalities and injustices. Next slide. I would like to thank you from the bottom of my heart for being here and listening to my presentation today. And I look forward to answering any questions you may have. And that's how to get a hold of me.
Mahado, thank you, thank you, thank you, thank you. That was raw, it was revealing, it was informative, and it was necessary. You provided information that will challenge us to recognize how we sustain and maintain these oppressive structures that allow the disparities to exist. And there are so many factors that you revealed that affect disparities that we can each start to address as we work towards helping our families with epilepsy and many other conditions. I love that you have identified some of the primary sources of the disparities being the patients themselves, our systems, and our practitioners and providers. It just kind of reminded me that when I think about the systems, one thing I wanted to lift was that, you know, in the US, we are the only developed nation in the world that has a healthcare system which does not see access to healthcare as a right of citizenship. The only developed nation. That must change. I too love that you lifted the 5 key areas of social determinants, which are neighborhood and built in the neighborhoods and our built environments. Again, with poor people and people of color being on that lower echelon, not having those accesses to education, housing, and good jobs. The other ones being health and healthcare, social and community context, economic stability, and education. So thank you, thank you, thank you for lifting those and just reminding us of all that we need to do. With that, we will begin our panel discussions. And I first would like to introduce our next 2 panelists. The first is Dr. Rupert Excande. Dr. Excande is an adult neurologist at Naran Neurological Clinic and is board certified in neurology, clinical neurophysiology, and epilepsy. His training included a neurology residency at the University of Minnesota and a fellowship in epilepsy, and a fellowship in clinical neurophysiology at the University of Minnesota. I'm sorry. His neurology subspecialties include seizures, epilepsy, concussion, and traumatic brain injury. He is a member of the Professional Advisory Board of the Epilepsy Foundation of Minnesota. His current and past appointments include neurology, an adjunct professor of neurology at the University of Minnesota, examiner for specialty board certification for the American Board of Psychiatry, neurology clerkship site director at the University of Minnesota, director of clerkship and residency at Minneapolis VA Medical Center Department of Neurology, and administrative chief resident at the University of Minnesota Department of Neurology. Dr. Excande, we welcome you. Our next panelist is Tameta Cozart. Thank you for being here. Our next panelist is Tameta Cozart, MS, MPH, CPH, and CHES, has over 10 years of public health experience and 15 years of experience in public relations and health communications. She is a former Assistant Health Equity and Communications Manager for the Directors of Health Promotion and Education, DHPE, and ASTHO, ASTHO affiliate nonprofit agency. Prior to working for DHPE, Tameta served as the Deputy Press Secretary for the Florida Department of Health in Tallahassee, Florida, as well as the Marketing Coordinator and Public Relations Manager for the department's Women's Health Program and Office of Minority Health. This Washington State and North Carolina native has a bachelor's degree in mass communications from Bethune-Cookman University, a master's degree in public health relations from Florida A&M University, and a master's in public health from the University of South Florida. She is certified in public health and health education. Tameta is currently pursuing a doctoral degree in health promotion and education from the University of Alabama. Her dissertation research focuses on epilepsy health disparities among minority populations. Tameta also serves on the APHA committee on the health equity as an appointed member since 2017. Tameta currently serves as Director of Multicultural Outreach and Health Equity for the Epilepsy Foundation in Landover, Maryland. To all of you, welcome. It is an honor and a joy to serve this day with you. Welcome. So guys, we've had some pretty heavy information on race and disparities in our country, throughout the world, and here in Minnesota. Before we begin discussion on that, I'd like for both Dr. Esconde and Tameta, beginning first with Dr. Esconde, to talk a little bit about yourselves, the work you do, and then we'll get into how some of this work affects race, racism, and health disparities in our practices and in the communities. Dr. Esconde?
Okay, so good. All right, good afternoon. Can you hear me?
Yes.
Is my audio okay? Okay, so yeah, I'm Dr. Esconde. I'm a neurologist at the Neurological Clinic. I started my practice about 20 years ago at the VA Medical Center in the University of Minnesota. That was my first 7 years. During that time, I developed special interest in epilepsy in the elderly at the VA. And then I was one of 3 epileptologists at the University of Minnesota during that time as well. While doing that, I was asked to see patients at what now we call Gillette Lifetime Specialty Clinic, which is a clinic for adults with developmental disabilities. After 7 years of being at the university and the VA, I moved to private practice at the Neuron Clinic. I've been there since 2000. I've been here since 2007, and so my the majority of my practice is epilepsy, and most of them are adults with developmental disabilities, and epilepsy, elderly with epilepsy. I guess that's all for now.
Tameta, tell us a little bit about yourself.
No problem. Thank you so much for allowing me to be here today. So I am the Multicultural Outreach and Health Equity Director for the Epilepsy Foundation. And I came to the foundation about 3 years ago. And how that occurred is that working at the University of Alabama in my doctoral studies, I actually had an African-American young lady in my class who was about 19 years old have a seizure. It was a generalized seizure, and she just described it as losing time, and that she had done that happened to her for about 10 years. She did not have a diagnosis of epilepsy. She actually didn't know that it was a seizure. I had been working in the health field for about 10 years, as you read in my bio. So I'd worked in state health departments, local health departments, community-based organizations, but knew very little about brain health. I had to do with epilepsy disparities or seizures at all, let alone its impact on communities of color. So that experience and me feeling are not equipped to be able to support that student just because of my own lack of information and education in that area, although I had worked in minority health for over a decade, drove me to actually want to learn more about epilepsy, the disparities that exist in minority communities, and how I can support that. And so over the course of the last 3 years, we have developed a multicultural outreach program that has been robust in terms of its partnership at the national level, its support of our network of the chapters and affiliates around the country, and also being able to address those culturally appropriate standards that were discussed in the presentation that we just saw. And so I'm extremely happy to be here. And this has been a great opportunity for me to also to be able to bring my multicultural media background to the foundation as well, to understand how important representation and having linguistic approaches that are appropriate to the communities is necessary and needed, and that it takes work. And we can do it through collaboration. So.
Perfect. So we are opening it up to questions and answers right now. So feel free to, for those of you participants out there in the audience, feel free to throw your questions in the box as they come up. I will send those to our wonderful panelists here. But to begin with, I was given a few questions by EFMN, and I'm going to start with those, and I will ask each one of you these same questions. Let's start with Tameta. How do these social determinants impact access and quality of epilepsy care?
I want to say, make sure I give kudos to Ms. Ali, because she did a wonderful job of setting the stage in terms of being able to highlight many of the social determinants that we see. I would like to highlight just a few in terms of from the Epilepsy Foundation's helpline. So we have a 24-hour helpline that we run. And one of the things that we have changed over the years is that we actually ask questions in that screening process that focus on social determinants. So we are now collecting information and being able to help individuals who are living with epilepsy or caring for someone who has epilepsy in areas that are beyond just their physical health. And so the areas that we get the most calls on have to do with transportation issues, being able to actually make appointments, even if you are connected to a specialist. We just, of course, heard from Ms. Ali the fact that many Black and Brown communities are not connected with specialists, which is one of major issues. There is not enough diversity in neurology field. I'm sure we'll touch upon that as well. But transportation is a huge issue, lack of being connected to specialists. Also, the aspect of food insecurity and employment. So those are two areas that we also find that even before COVID-19, we were getting calls in those areas and being able to connect individuals to local services so that they can be able to address those areas. Also, in terms of the aspect of COVID, I must also mention that the foundation has been doing what we call a pulse survey. And so that's been during the height of COVID-19. So the last one that we just completed was around April and May. So we found that individuals who are connected to specialists, they have been at adherence to being able to take their medication. They do have a higher socioeconomic level. They still have found great difficulty in this times of the pandemic around the aspect of losing their job, not making enough money to be able to afford their special care. So those are all things that have, we've been seeing at the national level.
Dr. Esconde, same question to you. How do these social determinants impact access and quality of epilepsy care, especially as you see it
Yeah. So it has been established at least, and we kind of know that these determinants are race and ethnicity, socioeconomic status, gender, geographic location, and payer source like insurance. I think what I'll do is give a couple of examples. So as a clinician, so 1 in 10 people will have a seizure. So that's not uncommon. We don't always treat people after the first seizure. But some of them need to be treated based on what we determine when we work them up. So that goes to access. Unfortunately, this happens a lot in my practice. A person will have a first-time seizure, end up going to the ER. It doesn't matter if they have insurance or not, they go to the ER. So that's okay. But the ER, the job of the ER doctor is to make sure that the person is safe and that it's a non-life-threatening issue. And then they have to be sent to the neurologist, and then that's where everything comes into play. Now, there's, at least in Minnesota, we're lucky. We have more neurologists per capita than in any other state. The problem is the location. Most neurologists are in the urban and suburban areas. So the access, if you're in the rural area, is difficult. Now, a number of these patients, if they don't have insurance, they know they need the workup, but they won't come to the neurologist. So then if they need to be treated, if we don't know that yet without workup, then it doesn't happen. If they show up for the appointment, some of them will not do the workup. Because it's expensive if they don't have insurance. Now, there are programs that we have for them, but it's not enough. We try our best to help. So that's the healthcare access, payer insurance part of this social determinant of it. The other extreme of this is, and this is a very specific patient that I have. So 30% of people with epilepsy will not respond to medication. Once you don't respond to medication, then we're talking about surgery and implants. So I have one specific patient who did not respond to medication. He's Asian American, highly educated. Well, when I saw him, he just finished high school. He was not able to go to college because of his seizures. Parents are highly educated, they're Asian American, And I explained to the patient and the parents that surgery or one of the implants the possible next option. They're okay with that because they're highly educated. But I didn't realize that in this group of Asian Americans, the grandfather or the grandmother makes the decision. So grandma didn't want to do it. And so that's a barrier that I had to cross. I had to talk to the grandmother, and so the patient and the parents, they speak good English, better than my English. They were born here, but the grandmother didn't speak English, and so now we do provide interpreters. By law, the clinic should provide interpreters, and we're able to do that. But we miss a lot as clinicians. We don't really know if they're getting what we're telling. Even if I'm talking to somebody in English, sometimes I realize just by body language that they're missing something. So that's an issue. And so this patient actually, after several appointments, which took over a year since I broached the idea of surgery, he ended up having an implant. And fortunately, he's doing well. He's in college. He's able to resume college. But he missed a lot just because of that. He's got insurance. He's got everything. But the race and the ethnicity aspect of this changed the access to medical care. So that's just an example. Now we're doing things for this. Those social determinants, we kind of know what they are, but there's really no comprehensive evaluation and data on that. The good news is that the American Epilepsy Society, which is the biggest group of epilepsy clinicians and researchers in the country, in June, they submitted this a request for information from the National Institute of Health. And this is going to be addressed because we cannot really perform comprehensive research without funding. And funding will come only if we have these problems actually defined. So things are being done.
I'm just curious, Dr. Esconde, you had mentioned that 30% of people with epilepsy will not respond to medication. Just out of my own curiosity, are we seeing that across cultural and ethnic lines, or is it just in general?
Actually, so this is an example. Before I came to the United States, I went to med school in the Philippines. This was in the 80s. We had a lecture about this. The attending told us, well, if you take your first medication for seizure, there's only a 50% chance of responding to the medication. If you go to the second drug, you're down to 15%. And then after that, it's about 5%. I was thinking to myself, well, we're in the third world. We don't have enough medication. This was a long time ago. Then I came here, and then in the early 90s, I was in training. This was actually studied in the United States and Europe, exactly the same findings. So it doesn't matter where you are. And then and during that time, we probably had 10 medications for seizures. Now we have over 20. It was studied again lately, same numbers. So 30% will not respond to medication. So epilepsy is an equal opportunity disease.
Okay, perfect. Thank you. Mahado, we have a question. So I'm just gonna, you pretty much covered that first one in your presentation. So I'm gonna direct this first question to you. And it says, how do we navigate and get services when we are getting discriminating against and in the marginalized community? How do we get the resources to what you offer? I have one child who was diagnosed, I think is what they're saying. We don't get access to services or say you're fine and my girls have been having symptoms. Thank you. Do I need to repeat that?
Yes, please.
Okay. How do we navigate and get services when we are getting discriminated against and we are in the marginalized community? That's the first part of it. The second part of it says, how do we get the resources that you offer? Or I think that is offered by neurologists. And then she says, I have one child who was diagnosed. We don't get access to services, or we're told, I think is what she's saying, you are fine, but my girls are having symptoms.
So I would say push, advocate for yourself, if you're a minority person, no one else would advocate for you. If you're in a marginalized community, no one else would advocate for you. You have to advocate for yourself. There were a lot of times, I'm a single mom and my son was born premature. So a lot of times I was told that we didn't qualify for the service or it wasn't available, when in fact I had to go to multiple different people to get that answer that they are available. So sometimes you don't have to stop at just that one no, you have to push for it. But also the services, if you go to Central Care, you can ask for the community health specialist, or you can ask for community health worker bilingual staff. So those staff will help you navigate. Our community health workers' jobs are to help patients navigate the system, whether it's housing, whether it's food, whether it's medication, whether it's neurologist. I was, as a community health worker, I've had patients come to me and I have to advocate for them. And I would oftentimes would go as far as getting lawyers into the mix, legal aid, to help them get the services and the resources that they want. So advocate for yourself and look for employees that are in charge of outreach programs, community health positions, or look for community health workers. In Minnesota, a lot of counties and health organizations have community health workers who are there to bridge the gap. Also, social workers have those services and resources. And I've had people from different hospitals and regions reach out to me asking for services, and I'm more than happy to direct anyone who has certain questions or need a resource.
Thank you for that. And thank you for identifying that community health specialist or community health worker, because I don't know that much of the public recognizes that there are opportunities and practitioners that are involved at the community level that people can go to for support and advocacy to help navigate through these systems. Tamara, I want to come at you with that same question, because I think working in the foundation yourself, you might have other resources that you can direct this woman to. Again, how do we navigate and get the services when we are getting discriminated against and live in the and are in the marginalized community? And how do we get the resources that are offered? She has a child that has a diagnosis, but they don't get access to service, and her girls are symptomatic.
Yeah, I don't have a problem doing that. I did want to make sure that Ms. Ali was able to finish. I felt like she
I'm
wanted to add
sorry.
something else. Did you?
No, that's okay. No, I was going to say that in Minnesota area, counties have community health workers, especially larger counties that serve minorities have community health workers. So you can go to your social worker, county office, human services, and ask for them to advocate for you.
Thank
Yes.
you.
And so with that, if you were to contact the foundation at the national level, we also help with that aspect of advocacy. If you really do feel like you are being discriminated against, then we do have procedures to help you to be able to navigate that system and to actually determine if there's a serious claim there or not. In addition to that, we can support you by making sure that you're being connected with organizations that do take on such advocacy, even if they're not focused on epilepsy. That's one of the things that I have brought to the foundation since being with them, is that we have decided to start working with the more minority health advocacy organizations at the national level. We bring the information about epilepsy disparities and what is happening with our community, but they already have the inroads in terms of the aspect of dealing with the discrimination around race and around bias and around having a lack of cultural competency with providers and how we can address that. And so we have done a lot more work of working with organizations like, Congressional Black Caucuses, the Hispanic Black Caucus, the Hispanic Caucus, Asian Pacific Islander community health organizations, the National Medical Association. So those are all provider focused or health policy focused organizations that we've been able to then work with the local level to be able to really have people that you can call if you truly do believe that you have exhausted all avenues of trying to get services and it's truly discrimination. Outside of that, I highly want to echo Ms. Ali's comment around the aspect of community health workers, lay health workers, and patient navigators. Again, if you find a group that is interested in working with you and they can help and support you, the foundation has training support that we can teach them and understand the nuances around epilepsy and epilepsy care. But at times you need people who have those navigation skills and can help you to get through these systems in terms of the fact that you've seen the barriers that you are coming across.
That was excellent. Thank you so much for that very insightful response and resource for people to go to nationally, in addition to just locally too. Rupert, I have another question here. I think I'm gonna direct this one to you next. And it says, as a 70-year-old, I've been living with intractable seizures for 57, I'm assuming 57 years. I had a brain tumor removed at 33 with surgery, was not aware that they were seizures until 1983. The doctor over the years just said it was in mine. Mine are drug resistant. So tired of neural workup. Do you have a response to that, or do I need to repeat that?
Yeah, no, unfortunately, again, like I said earlier, about 30% of people will not respond.
She just added mine are
Say
petite.
again.
She added mine are petite.
Okay, so that actually helps. Yeah,
Okay.
so again, 30% of people will not respond to medication, no matter what we do. Now, in the fatigue mal, I assume that you're saying they're not grand mal, you're not passing out, you're just experiencing something mild. Now, and then you mentioned something too about that your doctor said it's in your mind. And then, so I don't want to assume, but my assumption is the testing probably did not show seizure activity. And this is something important. If we do an EEG during a seizure, and the seizure is a mild seizure, like you're just feeling something, or you're just twitching a little bit, but you're not passing out or not losing consciousness, the chance of that EEG finding an abnormality is about 20%, between 50. So if it's normal, it doesn't rule it out. And so that's when we do more invasive testing. And in your case, because you have a history of brain surgery, I suspect that it will be coming from that area. So what we do recommend is do what we call pre-surgical workup, where we try to prove that that there are actually seizures and they are coming from one part of the brain. And if we try to resect that part of the brain, it will be safe. That brings up the possibility of seizure control really way up, over 50%. If it's a specific part of the brain, it can be 90%. So I will recommend, again, if you're in Minnesota, we have a number of surgical epilepsy centers in the state, and I think it will be you'll be best served if you get in communication with one of those places.
Thank you, Rupert. I'm going to go back to some of the EFMN questions, and Ms. Ali, you addressed these so beautifully. I just want to ask you once again, can you kind of outline what needs to be done to address inequities in epilepsy care?
So to address this, when it comes to immigrants and minority populations, it's two different groups. We have our own unique barriers and challenges, like Dr. Exogade, I'm sorry for butchering your name, has said before. It's not just about the patients and the parents who are educated, but it's also about the grandparents when it comes to refugee families, immigrant families. So with living in a multi-generational household, my son and my grandmother and I, and that's his great-grandmother, I also encountered some issues on getting my son the surgery and everything that he needs. So understanding people's cultures, number one, is important. We need to be able to understand the communities that we're serving and what their needs and barriers and challenges are. Also, we need to have interpreters. Oftentimes we hire we contract with interpreters with different agencies, but those agencies don't train their interpreters well. And not all interpreters are very well versed in every part of the health. So I was an interpreter for 10 years, and I can guarantee you that there are a lot of epilepsy words that I don't know. So it's important to have in-house interpreters. Like, we as an organization invest in in-house interpreters, and we put them our own trainings and education and everything, and our own testings to make sure that they are living up to our standards of healthcare, where a lot of times we contract, like I said, with other agencies, and they send, these young high school students or college students they speak broken English. I mean, broken Somali. Technically, it's not broken English, it's broken Somali or broken Spanish. So the message doesn't get across. Making sure that you, like, Tamara said, making sure that you invest in partnered organizations, fundings, create fundings for minority organizations to be able to help their own communities, to be able to help their own organization. When you teach somebody something, they're becoming more self-sufficient and able to invest back into their community. Hire staff that are from those communities that are able to understand and bridge those gaps. Also, there is a level of trust that it creates when a Somali person walks in, they see me, they automatically trust me, and that visit might go more smoother and better. Also invest in, diversity and inclusion education. Don't say we're about diversity, but actually be about inclusivity. Create community advisory groups from community members, bring communities together and say, hey, we would like to hear from you. What do you need? Because oftentimes we tell people what they need and what we think they need, and we think that one care fits all, but that's not the reality and that's not the truth. So being mindful and checking our own biases, educating ourselves, educating others, creating opportunities for employment, but also for the communities, and making these programs more inclusive is what I would say we need to do different. And also challenging these policies. I have a political science bachelor. I love politics. So at the core of it, I understand even the smallest policy, how that can get in the way of care or hiring or providing, diverse opportunities. So looking into those policies and seeing how they get in the way of somebody receiving care is very critical stage of change in an organization.
Cozart, do you want to add on to that?
Sure. I mean, she did a wonderful job, but I definitely also want to highlight the aspect of breaking down silos, right? So, one of the things I learned very quickly when I came to the Epilepsy Foundation is that we do a wonderful job of talking to each other, right? We have great relationships with all the other epilepsy and seizure related organizations. But outside of that, again, I think that's why, coming from a public health space, there's not a lot of information beyond that. So if you are not a specialist, if you are not someone living this life every single day, you don't understand all of those things. So it's hard to have this aspect of focusing on holistic approaches and focusing on social determinants when you have all of these other areas that do not know anything about having a seizure, what to do if someone has a seizure. But that's extremely important. And so helping to break down those silos, going to community meetings to talk about the aspect of seizure first aid, even if they're talking about housing, even if they're talking about transportation, those are still spaces in terms of the fact that they need to be educated on what people who are living with epilepsy are going through. And so I highly recommend thinking about, where are you not at the table? So we always talk about who should be at the table. Sometimes we don't think about ourselves, that we are not in rooms that we should be in. We are not in discussions that we should be in. From a national standpoint, to Ms. Ali's point about policy, the Healthy People 2020, there was a goal in there about epilepsy. Well, Healthy People 2030, there's not. So what has happened in terms of the aspect of us making sure that we're in the room when these types of discussions are being made? We must have that data, that came up in her presentation as well. Data is so important. We look at some of the racial and ethnic groups. For example, November is not only National Epilepsy Awareness Month, it's also Native American Heritage Month. And, we have to use the census from 2018 in terms of the estimation or the estimate that there's 51,000 Native Americans or Indigenous people living with epilepsy. There's very few studies that, we could reference coming up with this campaign, but that didn't stop us because it's extremely important for us to be able to talk about epilepsy with Native populations. And so those are the types of things I highly recommend we really look at in terms of breaking down silos and being a part of everyone's conversation. 40% of the 3.4 million individuals living with epilepsy are coming from a racial and ethnic population. So that is a high enough number that we should be discussing epilepsy and seizure-related disorders at every table of where we're talking about heart disease, of where we're talking about diabetes, and where we're talking about these other chronic conditions.
Okay, I have another question that I think we're going to try to get all of your responses in for, and that is thinking about cultural beliefs. How can someone encourage their family member to see a neurologist if their cultural belief is that epilepsy is a spiritual condition? Either of you, anybody can jump in because we're down to about our last 6 minutes.
I feel like I should yield to the clinician.
This is really, it's hard because we're at the other end of this. Education is a key. Now, I maybe we did not talk about this yet. So from the Epilepsy Foundation standpoint, we have this DEI subcommittee, the diversity, equality, is it equality or equity, and inclusivity. And we are trying, the plan is to reach out to certain segments of the population with epilepsy who are minorities. I think talking to them is the first step, because otherwise, I cannot. Once they come to me, I think I've done this long enough that I'm confident I can explain to them and I can convince them, even if it takes time. But them coming to me is the problem, and so and as a clinician, I don't have time for that. So that's why I'm happy that I'm part of the Epilepsy Foundation with this subcommittee where we are looking into this. It's a difficult question to answer, to be honest.
From the Epilepsy Foundation at the national level, I will say one of the things that, again, I've been working on is elevating the stories of individuals from certain populations that are willing to talk about culture and how that culture has impacted their journey. And that is the best thing that I can do, is to bring that person to a population that really will see themselves in them. Everyone is not going to be the appropriate messenger for every community. And so that work does take time. That is something that is not going to happen overnight. As I said before, we are currently working on the Native American campaign to increase awareness around epilepsy. And it has taken a while for us to find a recognized person from a tribe who is willing to actually share their story. But that person is incredibly invaluable. And it's not for us to try to exploit their journey. It is one that they feel like it is important for them to be able to talk about those cultural relevance in terms of what their grandparents, their ancestors, their history, their legacy tells them about this particular disease. That is not something that I am going to be able to tell them as a health educator from someone who's not coming from that community. So that has been our best opportunity to be able to influence, if that's what it is we need to do to try to influence change, to consider different treatments, is trying to have someone to be able to share in that. And even if it's not a person who is exactly from that particular population, especially in terms of a subgroup of a population, for example, again, we're focusing on Native Americans right now. There may not be someone who's from that exact tribe, but if the person is willing to at least share and talk and be able to connect with that aspect of cons and pros, both sides. It's not always the aspect of being able to talk about treatment as if it's glorious and it's going to, heal everything. We need to be honest about these discussions of the fact that, we're asking people to make very serious life and choices. So I really, highly recommend putting in the work to make those connections and collaborations so people can share their stories, especially from a cultural standpoint.
I did my dissertation on the power of story and healing in healthcare. And so you're speaking my language. I mean, some of the, not even just satisfaction scores of families, but their willingness to collaborate on what they're willing to do when their variance was completely different about what their healing ways were, as in contrast to the doctor. But the power of that story and a genuine sharing of it and appreciation for it built a lot of trust, a lot of connection, and a lot of healing ways. So you nailed it, which is why I really loved it that EFMN has really focused on sharing their stories for November Awareness Month, because we'll get so much further when we can understand the journeys, the paths, the legacy, the trauma, all of that our patients are experiencing, and we can walk better with them through those. I have one more question in 1 minute to get it all to you guys. Last question. Anybody can jump in, everybody can jump in. Are there any programs currently underway to improve health equity in epilepsy? And if so, are they working? Anybody? Someone?
So I'll say what we're doing at the national level. Again, to Ms. Ali's point, we are trying to put our money where our mouth is. We have actually, for the last 2 years, given out minority outreach grants. First year, we did that as an external strategy, focusing on minority health community-based organizations who did not specialize in epilepsy, for them to help us to be able to get inroads into communities that we have never been in before, because they had that trust. And then we taught them the aspect about, talking about epilepsy from a general standpoint, and then being able to refer to our helpline for, more, critical situations. But that has opened the door for the fact that we have been able to discuss a lot of opportunities that we normally would not have had by just going through traditional inroads. This year, we focused on trying to build the capacity of our network. And I'm very pleased to say that the Epilepsy Foundation of Minnesota, of course, is one of the recipients of those grants. But as Ms. Ali said, that we are extremely busy. Everyone is busy. So sometimes it does take funding to be able to have people focus and take the time and make the collaborations and do the work. That is not saying that they didn't know that they needed to do that before, but people should, your time is invaluable. So you should be able to be compensated for some of the things that you're doing, and grants and funds help and support that. I would also say that one of the things that's helped with that, and we're seeing at the national level, is that it's provided us with a network of individuals who are doing translation in languages that we, again, would not have access to, would not have been able to afford really the translation services to be able to get them done. But by working together and working through a community standpoint, our seizure first aid fact sheet has been translated into 10 different languages, and that's happened within this year. So within the aspect of the pandemic and all the other things that are going on, by having those many grants, that has helped us to be able to, support the work that our network wanted to do, but they just needed some resources, some partnerships, and, again, some examples. Sometimes, peer education is important. Seeing other people doing does help you to say, okay, we can do that. We can try that. And being willing to say, this particular subpopulation of my community may be small. It may be 5% of our whole state or something like that, but they're important, and we're going to spend the time it takes to elevate their voices. That has all come out of us having these many grants. So that's one example.
This has been the best 90 minutes that I've had in a long, long time. I am so honored to have spent this time with you. Thank you for the wealth and the phenomenal information that we've put out into our community. It has been an honor, a joy, and I'm going to turn it back to Heather, who I see her beautiful smile coming at me.
And I couldn't have picked a better way to spend my lunch hour. Thank you, all four of you, for joining us today. And those of you in the audience, thank you for joining us in this important conversation. If you have questions after this session is over, if you think of something after we're done, and often we do, please email us at admin@efmn.org, and we will work on answering the questions for you. Thank you for your time, and have a wonderful day.
Blessings. Be
Thank you.
safe, all.
Bye. Thank
Bye.
you. Thank you so much.